I'd like to start off by acknowledging the traditional owners of the land, and thank you to the organizers for giving me this opportunity to speak. So I've just recently done the 60K Coast Trek walk from Karamundi to Noosa, and that was on Friday. So you can rest assured I have no intention of standing here for longer than the designated 15 minutes. So unlike Jay-Z, he's a very popular American rapper. He has lots of problems, and I've decided to only talk about 5. And I've tried to focus on issues that are often overlooked. As humans, we're given the ability to use language to convey our thoughts, but we don't always use this gift, this skill, as best as we could. There's a lot of focus on communication within teams, but not as much focus on communication between teams. There's also specific times, such as times of crises and handover, at which things could go a little bit differently than the way we expected or the way we planned. There are some potential barriers to effective communication, such as hierarchy. Anyone who's ever had to convince a med-reg to call their consultant will definitely understand this. And there are other potential barriers, unsurprisingly, that involve cultural and language. That's a very, very true story. 2 surgeons, or let's change the story. It's 2 intensivists approaching an anesthetist or an intensivist. Close enough. It's the 1893 screen painting by Edvard Munch, and it just highlights the point that all communication interventions hinge on a culture of lack of fear, respect, good listening skills, and cultural competency. Conflict is there, and yes, surgeons are concerned about it too, but how do we improve this? We know that experience helps. In this survey done in the US, younger surgeons were more likely to report episodes of conflict than older surgeons. So experience helps somewhat, but we can't wait that long. We can't wait for everybody to get the experience. We know that surgeons often don't have the same understanding of what an open versus a closed ICU actually is, and much less of a problem, but it's something that we can actually influence. It seems like we live in parallel universes. The paper on the right is actually a confirmation that multiverses may actually exist. It's a cosmology physics paper written actually by my partner. He's the second author there. So he's quite chuffed that I put his paper on my presentation. But it seems like the authors on the left may have actually been onto something. There are several findings of interest from the study on the left. We do respect each other, it turns out. Surgeons and intensivists value each other's unique experiences and contributions, but yet each member of the team feels that they have a different understanding of the overall trajectory of the patient, and they have a more holistic view of what the patient's overall trajectory would be. And participants on the survey on the left described a disconcerting reliance on informal channels, such as drop-ins and sending messages through WhatsApp. All of these are potential sources of misunderstandings. So how do we solve this? The tribe mentality has to go. We're all part of the same team. We do ward rounds with ID physicians very, very well. Perhaps we should focus, put that much emphasis on doing multidisciplinary ward rounds with surgeons. Combined educational events, like combined conferences, may be another way to solve this. Give everyone the opportunity to feel and to share their opinions. This is a painting by a Spanish artist, Francisco Goya, called Saturno Divorando un Filo, or in English, The Consultant Devours the Registrar. I made that up, but it's Satan devouring his son. But apparently this is why registrars or trainees don't like calling their consultants on Sundays or on weekends. In a recent survey done at my hospital, the results of which will be presented in the Brisbane room at around 4 o'clock by Dr. Newton, over a third of Met team members in my hospital gave fear of response as a barrier to consulting their consultant. And I suspected that it's a bigger problem. Trainees don't want to be seen as not coping. And we have to foster a culture in which juniors feel at ease to call seniors, and they need to feel at ease to wake you up from your sleep. They should not be calling you, starting off with an apology. I'm sorry to be waking you up at night. I'm sorry to be calling you on a Sunday, you on-call consultant. A suggestion is to make it mandatory and not optional by instituting formal measures that can only be authorized by the treating team, consultant on call for every MERT call, or make it standard to consult and not an option. Handover in a standard critical care environment is a critical time. Someone's fatigued, someone's tired, someone knows the patient, someone doesn't know the patient. There's ambient noise, there are conversations in the next room, and lots of distractions, essentially. And handover during med teams in the wards are even more variable. I remember one of the first med calls that I went to in a geriatric ward. When I got there and I asked the nurse who triggered that MERT why a MERT had been called, she said because the patient was atopic. So I stood there for a second in bewilderment, wondering if I had missed like a whole chapter of medical conditions from my South African training. And the ICU nurse whispers in my ear, I think the problem is nurse acopia, which didn't help. She was joking, of course, but it illustrates the point. The same way we have in ED the SBAR mnemonic for handover, we should try and insist on the same kind of handover means in the wards. So perhaps the use of standardized performers might help. Other viewpoints that are often missed are the impact of culture and language to communication in general. In many languages, such as in my language or in Spanish or Cantonese, you'd never actually say, I cut my arm or I broke my arm if you didn't actually do it. You'd say that if you took a hammer and actually smashed it. But it's a common phrase in English. So you don't want to blame yourself. Why would you blame yourself for something that was actually an accident? So the language we use affects the way we think. It affects the information that is actually remembered. It affects the information that is relayed. And why is this important in ICU? Yeah, we work in a multicultural environment, and if we understood each member of the team, then we could institute measures to make sure that we all have the same kind of practice. And of course, if you're involved in an accidental event, you'd rather have a Spanish witness or a Spanish judge, because if they don't attribute blame to you, then they're more or less likely to punish you severely. But think of all the other labels that we put on patients' beds, MRSA, and patients can read this, their families can read it. And also, think about diseases like viruses or Ebola. It's been shown that if you categorize a group of patients, or be they patients or staff members, as victims rather than perpetrators, then you're less likely to, it's less likely the disease will spread. They're more likely to come forward because they don't actually blame themselves. Ethically and legally, all types of healthcare professionals have a responsibility to maintain an accurate record of healthcare records for their clients, and to ensure that this information remains private. We're pretty much very good at this in ICU. In fact, I think we document too much. Electronic records are essentially like another team member of the ICU team. But the cognitive overload from all of this data needs filtering, and the time and the cognitive overload from its assessment is also immense. And conventional EMR displays are filled and cluttered with irrelevant data. And ambient intelligent applications such as AWARE, which stands for Ambient Warning and Response Evaluation, may be a solution. There are some areas where we could improve, where we don't actually collect enough data, and these are situations such as documentation during MERT calls. We can improve this during standardized processes or forms to document events and rationale behind MERT team treatment therapies or therapies admitted during MERT calls, and at the organizational level through implementation of regular schedules to audit documentation completeness. And results of health record completeness audits could then be used to inform non-punitive QI activities. We're pretty bad at this at normal times. We think that it takes too much time. There's so many moments before you touch a patient, after you touch a patient, before the procedure, after the procedure. We blame visitors. We put signs everywhere, even though they don't actually work. So what do we actually do at times of crisis? I don't actually think we know. Perhaps we could try the big brother approach, have a designated team member in the unit or in the ward who stands there and taps you on the shoulder every time you breach an infection control practice. There's Edvard Munch again. This time it's 1896 and it's the deathbed. That's the med team trying to make an end-of-life decision. The early identification and management of the deteriorating patient frequently includes end-of-life planning, and more data is needed on how often med teams are involved in such decisions. In a recent systematic survey review, limitations of medical therapy were instituted in 1.7% to 30% of MERT calls, and also in the survey that's going to be presented by my colleague in the Brisbane room at 4 o'clock, RBWH had a significant percentage of med team members that felt that they were inadequately prepared to deal with end-of-life decisions during MERTs. Goals of care should obviously be held early in admission by the treating team, but end-of-life care should be a point of significant emphasis for training for med teams. Many of you will have seen that picture. It's a very famous picture taken by an American wildlife photographer. His name is Justin Hoffman. Yes, an earbud is not really a medical waster, but it illustrates my point. And it's increasingly clear that we have to consider the environmental impact of the healthcare that we provide. Waste management, unsurprisingly, is linked to cost awareness, and there are a number of drivers that we could influence that are driving planet plastic. And one of them, I think, is the drive or the move towards disposables. Because of the increasing cost of labor, we just want to throw things away. We can't clean them, we can't wash them, and for various other reasons. But additionally, there's a whole lot of excessive packaging that comes with the utensils that we use. We could insist on reduced wrapping and the marking of wrappings as recyclable by companies, if it is. That's a Sharps container with very few Sharp items in it. We contribute towards inappropriate waste disposal in the ICU, and there are other inappropriate waste disposal issues such as the discarding of drugs. For instance, propofol does not disintegrate in the environment. It's toxic to marine life. Often people throw it in the basin. It ends up in the sewage. Appropriate drug disposal systems should be in every hospital. We have until the 15th of October this year to advise the Australian Digital Health Agency if you don't want a My Health record created for you. And many people are opting out because of concerns with regards to privacy implications and fears of security breaches. How do we keep our patients' data safe as healthcare continues to be a lucrative target for hackers? And recently in Singapore, data of non-medical personal data of 1.5 million patients were accessed and copied, including national ID numbers, home addresses, date of births. In addition, outpatient data of more than 160,000 patients were compromised, probably including the Prime Minister of Singapore and Robert Mugabe of Zimbabwe, because that's where he goes for his healthcare. Other security concerns involve electronic transmission of confidential information through media such as WhatsApp. The simple act also of forwarding your on-call roster to your non-medical partner who organizes your life and your holidays is actually a forwarding of your colleagues' schedules and an entire department's activities. And with regards to my health, could insurance companies in the future use this data to establish individual risk factors? And what about privacy and ethical issues around genetic disease and implications for your offspring? And would privatization of this data management system in the future actually happen? And what are the implications of keeping this data for 30 years after your death in this ever-changing political landscape? And why is it an opt-out system? I'm not trying to paint a picture of darkness and gloom, but we should not underestimate the influence we have as end users. And at the very least, we have to be aware of the concerns and security features of any system that we're part of. Once a very, very important item, this is a king's seal. The seal of the king was so important that it could have been a matter of life and death. Only the king could use it. And now this 2,700-year-oold item lands up, is unearthed during an excavation in Jerusalem in 2015. Some would consider this a data breach of historical significance. And I'm proud to say that we completed the walk as strong position 6 out of 48 teams. And with that, I'd like to thank you for giving me this opportunity.